All right. Well, good morning, good afternoon, and good evening. We have guests from joining us from all over the world today, so thank you for sharing some of your precious time with us. My name is Andrew McLean, and I am the product marketing manager here at ADOC, representing our radiology portfolio of solutions. I am very excited today to introduce our two guest speakers. Dr. Nina Kotler is the Associate Chief Medical Officer for Clinical AI at Radiology Partners. She has been a practicing radiologist specializing in emergency imaging for the past 18 years. Combining her clinical experience with a graduate degree in applied mathematics, she has been using technological innovation to drive value in the radiology department. As an industry expert, Nina frequently consults for companies in aerospace, materials science, and healthcare, and is a frequent international lecturer discussing imaging artificial intelligence. Dr. Jason Poff serves as the Director of Innovation Deployment at Radiology Partners, where he has helped to lead one of the world's largest clinical deployments of imaging AI tools. He is also a practicing radiologist, specializing in abdominal, thoracic, and oncologic imaging for the past 12 years. His interests include the development of imaging AI best practices related to clinical validation and exploring the intersection of AI, radiologist workflow, and clinical quality improvement. As you can see, we have two very experienced radiologists who have truly turned their talents into understanding how to successfully bring artificial intelligence technology into the radiology workflow. Now, before I turn this over to our guest speakers, I would like to mention a few housekeeping items. This session is being recorded, and the recording will be sent out to all registrants after the session is over. Should you need to drop off early, or if you would like to share this recording with a colleague, be on the lookout for an email with the link to the recording in the next few days. Also, if you have any questions during the presentation today, feel free to share them in the Q&A box as the presentation is happening, and we will address as many of them as we can at the end of today's presentation. Jason and Nina, I turn the podium over to you.
All right, thank you so much, Andrew. It's a pleasure to be here today, and thank you to everyone who's joining us. Jump right in. Here's my financial disclosures. So my goal here today is really to teach you to evaluate AI models through the lens of a practicing radiologist. And, I think physicians have a unique set of priorities and clinical perspectives that are different compared to other stakeholders. And chief among those is our mandate under the Hippocratic Oath to do no harm. And so to me, that means we need to do our best to understand these new tools and technologies that we intend to deploy on behalf of our patients. And so, to that end, we'll teach you about our rigorous clinical validation process that uses a unique set of metrics that are relevant to the radiologist. We're also going to talk a little bit about thinking about sort of the educational framework and the engineering of our workflow and systems that we'll need to use to mitigate bias that can occur, when radiologists interact with these AI tools. So let's start up front by stating that the goal is not to evaluate the performance of these AI tools in a vacuum. We think that's actually a mistake. The AI models they're not intended for autonomous utilization, but rather they're supposed to augment us as radiologists, right? They're supposed to help us with our performance. And so our goal is to optimize the combination of the radiologist and AI. And we're going to show throughout the course of this talk that the way that we think you provide the best care, the highest diagnostic performance, you can achieve that, together by the complementary strengths of the radiologist and the AI. Now, when it comes to enterprise deployment of imaging AI, you need to provide oversight kind of at every step along the way, both before deployment, in real time to support your radiologist using these tools, and in an ongoing basis, in a continuous basis as you deploy. today we're going to focus on the clinical due diligence leading up to deployment, and we'll also talk briefly about how you can minimize the biases that can arise using imaging AI with your radiologist. On the pre-deployment side, the FDA really is involved in the business of proving efficacy, sort of in an idealized setting. We see our role at Radiology Partners as demonstrating effectiveness in the real world setting. And so we've developed a rigorous five-step imaging AI validation process that emphasizes certain performance statistics that are relevant to the radiologist. We calculate what we call the enhanced detection rate that I'll get into. We demonstrate that the AI helps us to find high clinical impact diagnoses. We also determine what the costs or the pitfalls of these tools are. And then we kind of have an objective way of weighing the pros and the cons to make a yes or no deployment decision. So let's remember, we're viewing these tools through the lens of the consumers of this technology, which, in our case is a busy private practice radiologist. And, we think that analogies are important when it comes to the AI. And I'm actually going to dive into this a little bit later in the talk. But for now, let's use the analogy of the radiologist as the pilot and the AI as a limited co-pilot. So if you ask yourself, what makes a good co-pilot? Well, you want your co-pilot to, number one, get your attention when it thinks you're making a mistake, right? On the flip side, you don't want it to waste your time with false alarms. And so with that framing, the way that we look at AI models is if it's providing us information that we think is useful or actionable for our patient and the ordering provider of the test, we're going to give the AI credit for that, right? We're going to count that as a true positive. And, in the course of our validation, because Radiology Partners is a national practice that serves all 50 states in the US, we're really striving to make sure that our AI benchmarks are representative of the diversity of the patients that we serve, right? That can be by geography, by practice type, or by the healthcare setting, whether we're talking teleradiology, hospital-based imaging, or outpatient imaging centers. So let's dive into the performance statistics. So these are the kind of traditional performance metrics that you'll read about in journals when it comes to AI model evaluation. So you'll hear about the area under the curve or the F1 score. And while these are important to the AI engineers, the data scientists, the clinical researchers, it turns out like they just don't register very well with practicing radiologists while they're reading cases, right? They don't necessarily have tangible meaning for us. And so we focus on some other more clinically oriented metrics. And let's look at that. We generally ask two big questions when it comes to these performance statistics. Number one, we want to know if the model performs as advertised in the FDA clearance data in a real world setting at a real world prevalence in our practices, like on our patients. And so if we look at this example of an AI rib fracture detection model, you can see that the FDA clearance data is generally reported on an enriched or an augmented data set. So it shows far more abnormal cases than in the real world. For example, here it's a factor of 10 times as great as the prevalence, 33 versus 3%. And so what we want to do is make sure that the traditional metrics like sensitivity and specificity hold up nicely in this lower real world prevalence setting, which we can see here. And then the second metric that we focus on intently is what the positive predictive value or PPV. This particular metric, it does tend to vary a lot from model to model, from AI model to AI model. And most importantly, it relates directly to the experience of the radiologist. So what exactly is the positive predictive value? Well, very simply, when you're reading a case and the AI alerts you, as you see here, if it's blinking, it's getting your attention. If it alerts you to the possibility of an abnormality, the PPV is the percentage of the time that the AI is correct. And clearly you would prefer the PPV to be as high as possible, 80, 90%. But you can also ask, on the other side, how low can the PPV get before the radiologist will lose trust in the models? In our experience, this is around a coin flip. So if the AI model is wrong more often than it's right when it gets your attention, we find that radiologists will start to disengage from the tool. And so I mentioned that PPV can vary a lot from model to model, and this is heavily influenced by the disease prevalence. So just as a refresher, prevalence is the proportion of a population that has the disease at a point in time. And there's a key point that PPV is predictably and strongly dependent on the prevalence, and it actually follows this mathematical relationship. But obviously, it's a lot easier to demonstrate this visually. And so here you see the prevalence on this graph on the x-axis, and the PPV is on the y-axis. And in this graph, we're assuming a sensitivity of 90% and a specificity of 99%. These turned out to be pretty good assumptions for many of the typical kind of current FDA cleared imaging AI models. Now, remember we said that radiologists are usually not going to tolerate a PPV below a coin flip, right? Well, we've represented this here by a horizontal black line at a PPV of 50% on this graph. And it's interesting, you'll see that the lines cross at about a prevalence of 1%, right? And below a prevalence of 1%, you'll see that the PPV starts to fall off a cliff. And so this is kind of that low prevalence zone where many of the current AI models will struggle to gain traction in the real world with radiologists. Now, luckily, it turns out that a lot of the diagnoses, these critical findings that we're trying to make, have an imaging prevalence above 1%. So intracranial hemorrhage is present on about 4% of head CT cases. Pulmonary embolism present on about 8% of PE scans. Rib fractures overall about 3%. And so they kind of fall in that range where we do expect decent performance on, a typical modern AI model that we're talking about here. Now, it is important though to realize that the patient location can have a big effect on prevalence. So if we look at the rib fracture model in particular, you'll see that in the ER setting and in the inpatient setting, rib fractures are reasonably common, right? So 5 to 7%. As you get in the outpatient setting, right, these are not necessarily patients that have had injuries, or at least most of them. The prevalence of rib fractures is below 1%. So we're kind of getting in that range where the model might not perform so well. It does turn out that there's a number of reasons that you might still deploy a model that's in this kind of lower performance range. And we'll get into those reasons later in the talk. So back to our 5-step process. Step 2 asks, does the AI model help us to make diagnoses that we might not routinely make as radiologists on our own? And before we talk about enhanced detection, it's important to be clear that we're talking about enhanced detection by the radiologist, right? These AI tools that we're discussing, they're specifically FDA cleared as triage and notification tools, right? They're not diagnostic, they're not detection devices. So this is actually how we teach our radiologists right up front. And we tell them honestly that, the buck still stops with you as the radiologist. These tools don't change that. In other words, the legal responsibility is still on you to make the detection, to make the diagnoses as the radiologist. So by enhanced detection, again, just to hammer this home, we're referring to enhanced detection by the radiologist that benefit from the awareness provided by these triage and notification AI tools. All right, let's dive into our rib fracture model again. And we can look at the impact on the radiologist with these AI tools versus the radiologist alone. So let's look here. So we have about 6,000 patients in our data set. Our radiologist found 114 rib fractures. The AI found 173. And importantly, 69 of those that the AI found were not seen by our radiologists without the AI. And so you can express this as an enhanced detection rate in 2 different ways. You can talk about a relative boost to detection, which would be 69 over 114, or a 61% boost to, on a relative basis. You can also express this as an absolute enhanced detection rate, which is 69 over, this 5,800 patients or so. And that's, a 1.2% enhanced detection rate. And, we measured these enhanced detection rates for every model we deploy at RP. And honestly, it's unlikely that we would deploy an AI model unless it has a positive enhanced detection rate to it. So the relative EDRs that you see here, they're a nice way to judge the impact of the AI models relative to each other. Because when you express it this way, you're essentially normalizing for differences in disease prevalence. If you look at the same data but expressed as the absolute enhanced detection rate, this is essentially, the radiologist miss rate, and it correlates more closely with the experience and the perception of the radiologists that they have of these tools because it reflects the disease prevalence, right? So, for example, if we look at the cervical spine fracture detection model, it has a relative boost to detection of about 16% in our data set. But because cervical spine fractures are rare on C-spine CT cases, the absolute detection rate is only 0.2%. And so let's look at that same data in a little bit different way that I think really helps the radiologist to, have proper expectations for these tools. So, as a physician, you're used to hearing about, in drug trials, they talk about the number of patients needed to treat to save a life or to, to have some clinical benefit. This is kind of the radiologist analog to that framing. And you basically can ask yourself, how many scans do I need to interpret? Do I need to read as a radiologist to such that I expect a benefit from the AI model? So if we look at this graph, like with the rib fracture model, what it's saying is about every 90 chest CTs, I can expect this AI rib fracture detection model to help me find a rib fracture that I might not have seen otherwise. And what that means is that's a weekly occurrence for a radiologist like myself. I'm a body radiologist. I read a lot of chest CTs. And that actually plays out pretty closely to how I've experienced these models over the last couple of years. On the flip side, look at the cervical spine fracture. So you are going to see a benefit, but it's going to take you longer to notice it. And this is just because of the disease prevalence, right? You're going to see this probably once a month instead of once a week. So again, this is a nice thing. We do show our radiologists this so they have proper expectations about, how to expect the benefit in the real world. All right. And let's put this all together in a nice kind of real world example with the rib fracture model. So in the ER setting, we said the prevalence is highest. It's about 7%. Remember, this is where patients come in with injuries. And so rib fractures are pretty common. And not surprisingly, the positive predictive value is quite high. So it's a very accurate model in this setting. And we do see that there's a boost to detection of rib fractures, which are hard to make, right? Every radiologist knows that it can be quite easy to blow by a subtle non-displaced rib fracture. And so it's nice to have the AI on board. When we look at the inpatient setting, the prevalence does go down a little bit. And as expected, the PPV drops slightly, but it's still very high. And it turns out that, most of these scans are ordered for shortness of breath or, some other reason in the inpatient setting, not necessarily an injury. And so radiologists are not primed by the history to look for rib fractures. And so we actually see a huge boost to detection. It about doubles the number of rib fractures that our rads find with this AI model on board. Lastly, in the outpatient setting, again, the prevalence drops off a lot. We're below 1%. As expected, the PPV, does decline. It's just above a coin flip here. But look at this enhanced detection rate. So, again, on the outpatient side, these are generally, staging exams for cancer, or the patient has a persistent cough or shortness of breath. And so a lot of these patients, they never tell you that, they bumped into their dresser a couple days ago, or they had a fall in the bathroom or something like that. You never get that clinical history. And so it turns out that, we miss a lot of rib fractures on the outpatient setting, even though they're less common on a prevalence basis. And so when you put this together, what we realized is we're willing to put up with a less accurate model in this setting in order to achieve this huge boost to detection. And so it's kind of a nice way to kind of put that whole story together. All right. So it is important, though, to show that the kinds of cases that the AI is helping you to find are clinically meaningful. And let's go back to that opening slide that I showed you. So I think we can show now that the impact of these AI tools on the standard of care is meaningful, but we can show specifically that it's the combination of the radiologist and the AI that results in the best care. So if we look at this graph, the dark blue cases that I'm showing you here, these were cases that were seen both by the radiologist and by the AI. Now, if we add on the light blue cases, these are the cases that were only seen by our radiologists in our data set. These were not seen by the AI model. And we actually know from our data that this is an underestimate of the number of cases that were only seen by the radiologist, but it's still nice to kind of visually show that there are some cases that only the rads are seeing. And if we add this vertical line here, what this is the standard of care without AI, right? These are all the cases that a typical radiologist in private practice on average is going to detect. And then if we add the last piece, we see these light orange cases. These were all the cases that were seen only by the AI in our data set. Uh, I think what's nice about this is that you can see that the best performance is radiologist with AI, right? AI alone, radiologist alone underperforms the combination of the two. And it is important to say, though, that this is theoretical data, right? This is a recent retrospective right before deployment. And in order to achieve this boost, you need to convince your radiologists that AI can help them make difficult diagnoses, right? You need them to be open-minded to that possibility. So, as they say, a picture is worth 1,000 words. And so we take time up front in our training sessions to show real-world examples of these enhanced detection cases. So let me just show a few examples of those here. Here's a 77-year-old gentleman who presented for a chest CT after he fell. And you can see the axial CT image. This is a nice example of a somewhat subtle rib fracture that was not seen initially. If we zoom in, we can see that this left-sided rib fracture, you can see, the fracture lucency. It's non-displaced, but it's a funny-looking fracture, right? It's got that lytic permeative appearance. And, we know as radiologists that this is a sign of a pathologic fracture. And it turns out that once we saw this, when you study the data, the imaging more closely, you see a lot of other sites of disease, unfortunately. And so the AI helped us to find an unexpected diagnosis of metastatic disease in this patient, to help make that diagnosis for the patient earlier than might have otherwise been seen. This was an unknown finding in this particular example. Here's another example we like to show. This is on the inpatient side, right? And this is a very kind of classic, complex inpatient postoperative scan. This particular patient had their right kidney removed 2 days before the scan for an upper tract urothelial malignancy. And they came in with some shortness of breath. And this is, again, a complex scan, right? They've got pneumothorax on the right side. They've got free air under their hemidiaphragm. They've got atelectasis at the right lung base. There's a pleural effusion. And if that isn't enough, oh yeah, it turns out they also have an acute pulmonary embolism. And so this is kind of another kind of classic clinical lesson that we see over and over again with AI, where it helps you to make diagnoses on complex scans with a lot of distracting pathology. And so we show our radiologists like, hey, it's going to be a nice augmentation to your regular practice, a boost, when we're making multiple diagnoses. It's going to help you to find that PE that you might have otherwise blown by. One more example. This is a 56-year-old man. He was not wearing his helmet when he got in a motorcycle accident. And you can see on this axial head CT image that there is some subtle pathology that, sort of the eagle eye radiologists on the call will see, but quite easy to miss. You can see that there is actually a small focus of hemorrhage in the left parietal extraaxial region. And it turns out to be a nice example of a coup type injury on this sagittal reformat. You can see the scalp hematoma and the bleed just under the calvarium at the same site. And so, again, a nice example of a recurring theme that we see where AI helps find subtle pathology, and nobody wants to miss a head bleed. So it's nice to have the second pair of eyes to help you out. All right, so we've talked now about how to get the most out of the AI on the detection side, right? But there's a flip side of the story, which is the costs associated with AI models. And it is crucial to your radiologist engagement with these tools that you educate them on the pitfalls and the limitations of the models. And so, besides the fact that radiologists can make diagnoses that the AI can miss, as I showed you before, one of the major reasons that we can't just let AI run autonomously is that they do raise false alarms, right? And sometimes fairly frequently. So we need radiologists to understand this, and we need them to be capable of overruling the AI, right? We need them to be confident enough to overrule the AI. And so here's a simple graph of the positive predictive value of each of these AI models that we deploy at RP. And, uh, these vary anywhere from just under 50% up to nearly 90%. But as we see, what this means is the light orange cases, if we allowed the AI to call all of these positive, all of these orange cases would result in significant unnecessary care, right? These would be unnecessary workups with unnecessary medical costs. And so we need to spend time educating our radiologists so they have proper expectations about the reality of AI overcalls and about the need for them to overrule the AI with some frequency. And so in my organization, we summarize all this important information for them into a kind of a one-page cheat sheet, which includes, all the performance statistics that we talk about, but it also includes a clinical summary. And in this clinical summary, we talk about the strengths and the weaknesses of the model. And we do this for every model. So for example, here's the one-page summary, the one pager we call it for the rib fracture model, and we can zoom in on sort of the typical overcalls and undercalls that we observe in the real world with this model. And this is part of our educational process for our radiologists. Obviously there's motion related overcalls, and the most common one is chronic rib fractures that the AI will occasionally flag. And then we tell them, listen, sometimes the model has trouble finding rib fractures near the costochondral junction. And so we kind of provide a few tips and tricks for each model on how to get the most out of these models. But let's be honest about our, this is a tricky dance, right? Like going back to this slide, we need radiologists that are open-minded enough and humble enough to rely on the AI to capture this boost to their detection, right? We need them to not be too quick to dismiss the potential of the tools. But on the flip side, we need them to be skeptical enough and discerning enough and confident enough to serve as a counter to the AI and to make sure that the patients represented by these orange bars don't go through unnecessary testing, right? And unnecessary, care for false alarms. And honestly, this is not an easy educational mission. It's, you could liken it to parenting or mentoring. Like it's a high effort process. You have to be very engaged and take the time to educate your rads on how to get the most out of these tools. I think, in addition to the economics of this getting worked out, it's part of the explanation for why adoption of these tools is, a little bit on the slow side. And, basically what we're talking about here is how do we mitigate the bias between the radiologist and the AI? You can simplify this into kind of two dominant categories. Number one, you can have over-trusting, right? You can have, we call this automation bias, or you can have complacency bias, where the rads, for whatever reason, they just accept the AI result without questioning it, without being skeptical. So you don't want that. But something that's probably not talked about enough is the flip side, or, the distrust bias, where rads are inappropriately throwing away AI flags where it turns out the AI is correct. And so you need ways to mitigate both sides of this. And I'm just going to take a quick tangent here. Like, in some ways, I don't think we've arrived at the right analogy for how to think about these imaging AI models, for the benefit of our rads. How do we teach them how to think about these? It's super interesting and fun to go into the technical understanding and providing this kind of framework for rads. Like you can talk about convolutional neural networks, teach them about transformer models, attractor basins, feature space, embedding space. It's all really interesting. But again, it doesn't really resonate on a human level for a user of these tools when you're reading cases. I do think it's important that we all just realize that ultimately, on a fundamental level, they're mathematical equations that are crunched to kind of arrive at some sort of statistical probability of sorts. But again, like you need a better analogy for our human rads to understand these tools. When you look into these kind of hidden layers of the neural networks, you see these strange outputs, and you can realize right away that it's really speaking a different language than us humans, right? And it's undeniably kind of alien-like. Even these heat maps, you look at it, it looks cool, but it's very strange looking. And so it makes you think like, should we try to anthropomorphize the AI? I think a lot of kind of AI thought leaders would scold us for considering this, right? Like they would say rightfully that, by doing this, you're kind of ascribing more insight or skills or power to the AI models than they truly have. And that is true, but the reality is that if you give the AI sort of like a human-like identity, it allows us as human radiologists to use the opportunity to consider that the output of the AI models is basically just an opinion, right? And so we can treat them like an opinion, just like we would for a radiologist colleague. And, in the same way that if you ask one of your friends that's a radiologist for an opinion, you might accept that opinion, or you might consider it and change your opinion, or you might discard it entirely. And so I think this is kind of a helpful framework. So you need an analogy that captures, the power of the AI models and the potential, while also acknowledging their fallibility and sometimes, honestly, even their like childlike kind of silly mistakes, because sometimes it's just, very obviously wrong. So, we've all seen Clippy, in Microsoft. That's not going to cut it, right? Because nobody looks at Clippy and thinks that that's, a smart AI model. But on the flip side, you don't want our rads terrified of these models, right? Like we don't want them thinking about, scary aliens. So this is kind of where I'm at right now. I'm sort of think of these models as, a childlike alien prodigy, somewhere between like a Wall-E or an R2D2 or an ET, something. To me, this is a helpful framework because it allows me to, give it an identity, and but also realize that it's powerful but flawed, right? Like a childlike prodigy. All right, let's get back to kind of our story. So, despite the difficulty of conveying this sort of push and pull between the power and the peril of the AI models, it is what energizes me, right? Like there's so much to understand. There's so much to learn about this new symbiosis between human and AI. And there's going to need to be a lot of innovations in terms of new workflow, new systems engineering to help radiologists understand when and how much to trust the AI. One of the ideas that we're excited about at RP about exploring is sort of what we call the AI traffic light. And what we're hoping for is some kind of tool in real time to give more guidance to the radiologists, right? To tell them while they're reading the cases, hey, you should use extreme caution with this AI result in this specific instance because, maybe there's severe image quality degradation, or maybe this specific case is using a new protocol that is out of distribution for the way that this AI model was trained. Or maybe just the AI result is on the lower end of their confidence range. And so, I think as radiologists, we would love this information in a simple format to allow us to, kind of put it in the best context. On the other end of the spectrum, we should be telling our radiologists when it's a very high confidence AI result. There's even some innovative groups that we've seen have instituted new workflows where they will do double reading of cases where if the radiologist disagreed with a high confidence AI result, they'll get another radiologist to take a second look because a lot of times the AI was correct. And so these are the kind of things that we're excited about exploring and, potentially building new ways of practicing radiology in real time based on the AI result. And so we're excited to do that. All right, let's get back to the validation. One more kind of fun little metric that we've come up with to help you weigh sort of the positives and the negatives about these models is what we call the gain to pain ratio. And it's very simple. Basically, like when you do one of these validations, if you simply take the number of what we've called these enhanced detection cases, remember, these are the cases where the AI has helped you find true pathology that might not have been seen by the radiologist. If you take those cases and divide it by the number of false positives, the AI false positives, you get a nice ratio. And when you graph this gain to pain ratio on the y-axis and the enhanced detection rates on the x-axis, you get a nice visual comparison of the AI models. And it does turn out that this gain to pain ratio does a nice job of mirroring sort of, how radiologists subjectively experience these models in the real world. If a particular model, if the gain to pain ratio is 1 or higher, our rads typically tend to like using these models because the benefit clearly outweighs the false positives, the false alarms. And so, when we've started surveying our rads about these models, their two favorites so far are this incidental PE and the PE models, both of which, fall nicely on this graph. On the other side, like if the gain to pain ratio is below 1, it just means that you need to think more carefully about whether the model is deploying. Now, I'm going to show you in a second, there's a number of reasons why, we have decided to deploy models in this range. They're less accurate, but there's a lot of good reasons to still deploy them. All right, let's summarize. So here's kind of a nice objective checklist for kind of summarizing everything we've talked about so far. So number one, like do the performance statistics using a real world prevalence, do they hold up nicely to the FDA clearance data? Number two, is the positive predictive value high? Is the AI correct, most of the time when it's getting your attention for a possible abnormality? Number three, is there a boost to detection? Do you find that your radiologists are making extra diagnoses with this AI tool on hand? Number four, are these clinically meaningful enhanced detection cases? And number five, is this gain to pain ratio 1 or higher? If any of these criterion are not met, you can go to this kind of further justification checklist. And these are, probably not all the reasons, but at least some of the reasons why you might still deploy a lower performing model. For example, there's certain diagnoses that come with a high medical malpractice liability. For instance, in our data set, we find that bowel ischemia with free air, that's something that is obviously super important to detect. And ADOC has an intra-abdominal free gas model that we have deployed. It's not quite as accurate, but it is really nice to help you find these cases that are super high clinical impact. They're not common, but we're willing to put up with more false positives in order to find these needles in a haystack. Number two, anything that's high clinical impact, like a treatable brain aneurysm, a fracture in the cervical spine, that might need surgical fixation. Again, these are reasons that we'll put up with lower accuracy in order to get that important clinical gain. We showed you the example of rib fractures in the outpatient setting, not that common overall, but also, a lot of these are overlooked by radiologists because of the nature of the clinical histories they're given in these settings. Having the AI model on board is really a huge boost. And then one other reason, there's certain diagnoses that, we've all got long lists these days. There's certain diagnoses that you don't want sitting on your outpatient list over the weekend, right? If you have a child that has a fractured ankle or something else, you want to diagnose that as soon as possible. Similarly, we're talking about pneumothoraces on chest x-rays, right? Nobody likes reading those 2 or 3 days after the image has been taken. So we'll put up with, kind of lower accuracy if that brings the case to the top of our list and allows us to make the diagnosis as soon as possible. All right, coming to the end of the talk here, and I think just in summary, what we'd encourage you to do is we want you to develop and kind of follow a standard clinical validation process before you deploy, and try to focus on clinically relevant metrics that matter to the radiologists. The ones that we've suggested and talked about today are the positive predictive value, the enhanced detection rate, and this gain to pain ratio. And then lastly, I hope, we're started to get you thinking about what are the ways that you can mitigate rad-AI bias, as we deploy these new tools, as we learn how to best take advantage of them. All right, thank you so much. I'm going to stop screen sharing there, and we'll turn it over to Andrew.
All right. Well, first off, Jason, thank you. Incredibly educational and very easy to digest. Statistics is not something most of us are comfortable with in our normal lives, but you really did make it digestible and understandable, and I greatly appreciate that. There have been a few questions that have popped in, and I'm going to kind of let you and Nina fight for who wants to answer which one. So let's have some fun with this. My first one that I saw is what prompted you to undertake doing this research about how AI is perceived by the radiologists and how it performs in your organization?
Andrew, I'll get started with some of the questions. So that's a really good one and an important one. It is well known that AI models don't automatically generalize, meaning they're brittle. What does that mean? It means that they can't necessarily expand their understanding in a way that humans can beyond their training or far beyond their training. So if your AI model is not trained on something in particular, if that data we call is out of distribution, the output that you get may not be as high quality as you might expect from the other output. And it's hard to know that because you're not sure when you get the data, is it out of distribution from the training? Now, that's very different than a human. And this is why it's important that Jason talked about humans tend to anthropomorphize any tools, and they're very different. A radiologist could go down the street to a very different hospital with different protocols, different scanners, different patient population, even perhaps, and they could do just fine reading those studies. In fact, they might not notice that much of a difference, but an AI system will. And it won't necessarily be able to do what we can do. So it is important to make sure that we recognize that these models can err depending on how they were trained. And so it's important for anyone to test a model before you deploy it. You want to make sure, as the clinician, that you're providing safety to your patients. The other thing that Jason talked a lot about is setting expectations. These AI tools are clinical tools. We might think of them as an IT tool, like, oh, it's going to be like an upgrade to my VR system or to my imaging viewer, but they're not. They have to be trained, and expectations have to be set by clinicians. And so doing this validation, we take so much of this information and we use that information after we generalize the findings to educate our physicians so that they do consume these models better, so that we decrease that bias between radiologist and AI. And so we set expectations. So the outpatient rib fractures, if we went in and said, hey, these are going to work just as well as your ED rib fractures, then we're not setting expectations appropriately. And it could be easy for a radiologist to dismiss the tool if they're in an outpatient facility and they're reading mostly outpatients because they're going to get false positives. And here you are advertising that these models are great. You have to set expectations appropriately.
Actually, there's a question that kind of builds on that. And so you folks rolled out your rib fracture in the emergency department first and then expanded to support outpatient later. Would that be your guide, I guess, for anyone listening here? Is that what you would recommend to help set those expectations?
It's a really interesting change management question, right? Your question is not about quality of the AI, it's about your change management process and how you can get radiologists to accept and engage with these tools. And people completely underestimate that. So as Jason said in his presentation, the highest prevalence for a rib fracture, and these are all CT, found on CT imaging. So the highest prevalence is in the emergency department setting. And that means that you're going to have the highest positive predictive value there. So your AI is going to feel to the radiologist like it's the most accurate because it's not overcalling too many, it's not producing too many false alarms. The lowest prevalence is in the outpatient. And so you could, if let's say your physicians are a little more skeptical about AI, or maybe you don't have time to speak with each of your physicians and set expectations appropriately. Maybe they're less willing for change, or they recently went through change. Whatever reason that is, you might decide to just roll it out where initially you're going to get it on your highest prevalence disease, because that's going to give you the best results for your radiologist from a positive predictive value. The downside of that is that the AI is not analyzing every chest CT case. And as a radiologist that's consuming these tools, you're not necessarily looking, where is this patient from? So you open up a case may be from the ED, and you'll get an AI result. Then the next case you open up might be an outpatient, or it might be an inpatient, but not through the ED, and you don't get a result. And RADs can get confused if you're not setting expectations. So after doing all of this, we found in our organization that downside of people saying, well, no, I really like this AI model. It's awesome. I want to have the result on all my cases. That was worse than the frustration from overcalls. So,
Okay.
so I think it's up to you, but
Yeah.
realize that it's a change management question.
Brilliant. Brilliant. Okay. Another question that may be treading on some sensitivity, so we'll see what you think. Does Rad Partners save the AI results in a way that might be seen by clinicians, patients, admins, and that bad word of lawyers?
So a question about sort of legal liability is enabled through maybe an AI says something, and we know AI is not always right. The standard of care is the radiologist, and so the radiologist should be able to make that decision. But what if someone sees the AI result? Couple of opinions I have about that. Number one, there was a paper that was written about chest X-ray. They did an evaluation to show that the AI results on a chest X-ray model were put in the PACS system. And then they looked at how much automation bias was increased by that, by just putting results into your PACS. And they found with radiologists that automation bias was increased because when you put those results in PACS, other people have access to see those results. And it makes some RADs unconsciously or consciously biased and saying, well, maybe the AI is right, I might hedge or something else. And I don't think that's the best way to manage patient care. So we actually don't put our results in the PACS. I'm less concerned right now about lawyers seeing it. I'm more concerned about a referring clinician seeing it and then acting on those results because they don't recognize that, number one, AI is not the standard of care. And number two, they haven't been educated about how the AI works, and they might not be educated enough about imaging to be able to adjudicate appropriately. So they may look at that and take action. And I don't think that's appropriate right now. Now, in the future, if PACS has the ability to limit who can see these results and when they can see the results, or if the radiologist could interact with that result. Right now, these are usually sent across as a DICOM SR, a secondary capture, and maybe a GSPS that you can't really interact with. At most, you can toggle it on or off, but you can't say, I'm going to change this result and have the AI rerun. In the future, that will be doable. And then after that, if the radiologist has interacted with the AI result, then I think it's okay. From a legal standpoint, the standard of care is the radiology. That may change in the future as we start using AI more and more. And at that point, we should have more discussions and thought about how we manage that.
Brilliant. Are all of these pilot evaluations done in the ADOC platform, which I think the answer is yes, but how long do your pilots typically run?
You know, in the beginning, we used to run all of our pilots as a true pilot where we would deploy it in one location at one of our sites. And we would either deploy it in the background so the radiologist didn't immediately get the results, but we would review them all after. We learned a massive amount that way. Or sometimes we'd run a pilot where the results are visible and we've educated the radiologist about it so that we could glean some insights. What we found is that if you're going to scale your processes, there's so many AI systems out there and you want to be able to validate many of them. It used to take us 6 months to run a pilot. It takes a very long time to do things that way. It just is not scalable. So what we've done now is we actually have extracted the validation outside of our clinical environment. And we do a few things. One, we send it to, we basically send studies to the AI system. The AI sends us the results back, and then we adjudicate them outside of a clinical live system. So this can be done in a matter of days. If you just have enough images and variable images, you can send it to your AI vendor, just make sure it's de-identified. They will provide results back to you, and then you can adjudicate. And what we tend to adjudicate is anytime the AI system says there's a positive, or anytime the radiologist through the report says there's a positive. And we can do that review generally in a couple of weeks. So that can happen much more rapidly and tends to be more effective. Now, the pilot, when you're actually running it live, you're learning a lot of other things. You're learning technically, does this work in your system? Is there an ROI? And so we evaluate those at the same time. It's just done separately. And Jason didn't, that was not the point of this conference to specifically talk about how we do our technical evaluation and our ROI evaluation. However, we do those as well. And we have figured out how to do them much more efficiently than when we ran our 6-month pilot live.
Right.
And I think I'll just add one thing, Andrew, is that, for the radiologists and even the executives out there, it's worth investing the time to do this if you have the resources, partially because you learn so much about the tools, and in the process of evaluating them and validating them, you become an expert in a sense, and you learn a lot clinically. I think one of the things that I enjoy the most about AI is that it's kind of a mirror on the way that you practice radiology, right? It's constantly testing your own clinical assumptions, challenging you. And it's the same thing when you do deploy. It's part of why it's so important to have a robust feedback mechanism and a dialogue with your radiologist, because they're going to constantly challenge you about, kind of the edge cases that they see, or even something that they don't understand. And if you've put in that kind of groundwork up front, you can really be that champion, that person that, kind of helps to translate them to the real world setting.
It's actually a really important point, because a lot of people are afraid that if we start using AI, we're going to rely on it and we're going to lose our expertise in these areas. And that's not necessarily the case. If you are intentional about what you do with it, then that doesn't happen. So if you, let's say residents, if you're worried about residents relying on it, have the residents do this evaluation. I work with Jason on all the validations because I love it and I learn a huge amount. I became a better rad after I did every single one of these validations. And if that's part of their training is to do the validation, then they're going to learn a massive amount. And I don't think they'll lose their expertise.
Awesome. A little bit related, but there's a question pertaining to your research in this. And are you doing any sort of bias analysis on subgroups, things like race, gender, age, etc.?
It's a great question. Our processes are always evolving. When you are trying to be out in front, creating best practices, there's no endpoint to that. You do something, you create a form of best practice, and then the next month you improve it. And so the point that we're at now that Jason showed you is the point we've gotten to after a good amount of time of doing this, but it's not our endpoint. We do some analysis of subsets. So we've split it up into different patient locations, but we haven't done enough of that. And that is on our docket for next time, because you may have something that's out of distribution. Maybe it is a patient race, maybe it is a different scanner type, but they're not all going to equally affect the output. Some will affect it more than others. And so understanding which subsets are not just out of distribution, but what subsets are getting you your bad results are really important. So that is something that we are evolving to and working on actively.
Very cool. So related to the training, there was a question about how much time do you spend training incoming radiologists on this entire system?
Training is not a one and done. We want to make sure, I mean, gosh, if I could, I would personally train every single radiologist. I would go to their house, I would go to their hospital, and I would sit with them for 30 minutes, and then I would go back, every 2 weeks and just say, hey, let's talk about this again. When you might be able to do that in the beginning, but once you start scaling your number of products and your organization, it's just not possible. So we We try to do a lot of different ways to get to educate our radiologists. So before a radiologist uses a AI system, we go through a group training where we talk to them about what are the findings that we found, where does it tend to make mistakes, where does it not tend to make mistakes. We have those videos. Anyone could access them at any point. We keep a whole bunch of information also on our internal RadWiki. We have monthly reviews where we talk about different subjects that people have been bringing out through feedback. And we also have AI champions within each local practice, because Jason and I, Shreyesh, Gina, the other people on our AI team, we're only a set of what, 5 or 10 rads, and we have 3,000 radiologists. So we utilize other radiologists internally within each practice, and we educate them to a much higher level. We have monthly meetings with them. And then we do some peer learning to bring up cases where AI is making mistakes, and we try to showcase those peer learnings as often as we can, because this has to be a continuous education process.
Yeah. One last quick question, because we're just about to close. If you were to provide one piece of advice for the audience today, what would that be?
For me, it would be open to change. When we say AI won't replace radiologists, which I think is true, it doesn't mean that our jobs aren't going to change. And they're not changing that much right now. I think when you deploy AI, you shouldn't just deploy it, plop it next to you, and practice the exact same way. You should modify how you're working to best consume the AI so that our patients are getting the best result. And there's going to be far more change in the future. I would ask every radiologist to embrace this change, learn about, develop expertise in imaging AI so that we, as the imaging experts, can help drive where this technology goes.
Jason,
Hard
any
to,
last words?
hard to top that. I would just say the same thing. I would say dive in. Don't be afraid to dive in. I think, like I said earlier, it's very satisfying to see how intimately related AI is to your quality processes. And, it's fun for me because it does, kind of level you up, and it challenges, like I said, a lot of the way that you practice, and makes you, I think it makes you a better educated and more engaged radiologist, honestly, to start diving into these tools. And I think we'll see over time that it's going to merge even closer with all of our quality and patient safety processes.
Fantastic. Well, this has been absolutely brilliant. I will admit we could not get through all the questions today. For those of you that I did not give you an answer, we will be reaching out separately. But thank you all for your time. And thank you, Nina. Thank you, Jason. This was fantastic. Have a great day, everyone.
Thanks, Andrew. Thank you,
Thank you,
everyone.
Andrew. Thanks.